Good evening. Every second Saturday, AIOS conducts practically oriented webinars, which are aimed at general ophthalmologists on topics of interest to comprehensive ophthalmologists. And these are case related and interactive. And today we have a very important topic to touch upon, that is dealing with patients who are glaucoma suspects. The meeting is being chaired by Dr. Amanjit Sihota, who was my teacher, professor of ophthalmology formerly and currently with Shroff Eye Center, New Delhi. Dr. Harsh Kumar, again my teacher, currently at Center for Sight, New Delhi. Dr. Satyan Parthasarathy is the current president of Glaucoma Society of India from Satyan Eye Care Hospital, Coimbatore. Moderator and the program director is Vinita Ramnani from Bansal Hospital, Bhopal. Expert panelists are a stellar lot consisting of Dr. Madhu Bhadoria from Regional Institute of Ophthalmology, Eye Hospital, Sidapur. Dr. Manavdeep Singh from Ram Manohar Lohia Hospital, New Delhi, who is the former secretary of Glaucoma Society of India. Dr. Mayuri Khamar from Okura Eye Care, Ahmedabad. Shweta from Indira Gandhi Eye Hospital, Lucknow. And the presenters are Dr. Ankur Sinha, Devang Angmo, Pradeep Vyas, Siddharth Dikshit, Sushmita Kaushik, Vanita Patakre, and Venkatesh Rangaraj. That's the extensive program that we have, and most of it is case-based and interactive. And Vinita will take over from here and run the show.
Thank you, AIOS, and I welcome all the speaker, panelists, chairpersons. We have galaxy of glaucoma expert from all over India, and I am thankful to AIOS for making us showcase the glaucoma suspect cases, because these are the commonest cases which we usually see in usually the other glaucoma expert, the other comprehensive doctors, they see in their day-to-day practice. And I think probably in ophthalmology, this is the only one disease where we can definitely write it as a glaucoma suspect. Otherwise, nobody will write like a disease which is suspect. So without wasting much time, it's I will invite Dr. Samar sir for his opening remarks. His sir is here.
He's not joined yet. You can go ahead with.
Okay. So Dr. Satyan.
Okay, I have a few suggestions to the speakers. I think most of the talks seem to be related to open angle glaucoma. I think while they're talking, they should keep in mind that angle closure is a very large segment. So shallow ACs, gonioscopy is important, and a very large other segment is secondary glaucomas. So when we talk about walk-in patients, keep in mind all three groups of suspects.
True, madam. Very valid point. Dr. Satyan, some opening tips for the webinar.
Good evening, everybody. First of all, a sincere thanks to Team AIOS and Dr. Santosh, and of course, big thanks to Dr. Vinita for arranging this wonderful meeting. Yes, as we discussing that the glaucoma suspect is one of the very big topic as such, because many cases are inconclusive for us to whether to treat or not to treat. So today's sessions are going to be very useful for the practicing ophthalmologist, especially the general practitioners, to see what are all the points that we can take home, so that we can practice comfortably. So thank you, AIOS. And on behalf of GSI, one more time, we would like to thank AIOS. And I think we'll just move on to the session now. Thank you.
Thank you. Thank you, everyone. And now, with the permission of the chair, ma'am, can we start? The first topic is being taken care by Dr. Siddharth Dikshit. In spite of a function at LVP, he agreed to do this. Thank you so much, Dr. Siddharth. So he will be talking about what is actually glaucoma suspect consist of and what is the importance of intraocular pressure.
Thank you so much. And it's a matter of great privilege and honor to be in such a group. Many thanks to AIOS and Dr. Vinita. So I will be very practical and go through cases and not repeat some theory from a book or a guideline. And I'm talking about the Trishankus of the glaucoma world, the glaucoma suspect. And I will start with the first case. when IOP misleads. So this is the
Can you,
story.
this is the presenter's view, I think. Can you go to slideshow if possible?
Oh yeah, okay. Is it the normal view now?
No, it's still the presenter view.
Okay. I'm a little surprised because I can see a normal view only. Just give me 1 second to sort this out.
Yeah, perfect.
Right. Apologies for that.
No.
So a lot of suspense was on card, so I didn't want you to see the next slide, obviously. Thank you, Dr. SH. So this is the story of a 66-year-old retired professional who came with absolutely perfect vision for a normal checkup. And the intraocular pressures were 22 and 21. Angles were open, and you see here, this is what the disc was like. And you can see that the cupping in the right eye is 0.8, left eye is probably 0.7. And he was diagnosed as glaucoma elsewhere. And before we proceed any further, we did a CCT, and it was 594 and 598 microns. Visual field in both eyes was normal. The OCT was basically not commenting on the neuroretinal rim thickness. And if you want to know why, look at the disc area here and close to 5 square millimeter area. And this is one of the largest discs that I have personally examined. And if you look at the RNFL thickness and the GCA, they were both normal. So there was no evidence of glaucoma in this eye. And why this became a problem? Because the intraocular pressure was high, along with the very, very misleading appearance of the optic disc. So we have to think of the optic disc size before interpreting cupping. Remember CCT before interpreting intraocular pressure. If you don't have an ultrasound pachymeter, most of the biometry machines these days will give you a CCT. And before you forget, cupping is no longer a sign of glaucoma, according to the American Academy of Ophthalmology. You have to look for changes in the disc or the rim, or note a progression of cupping to call it glaucoma. Don't go purely by cupping, especially not without looking at the size. The second case, I will be as fast as possible. When we misread IOP. Now, this young lady was told that she needs an eye stent inject because her intraocular pressures were not coming down from the baseline and not controlled enough. Her intraocular pressures, sorry. Yeah, this is the pressure that we checked 16 and 14. But just before she came to us, this is what she had. Pressures varying between 24 to 27 in both eyes. And despite all medications and advised glaucoma surgery, eye stent, her disc was fine in both eyes. This is her visual fields completely normal, and the OCT again not showing any abnormality. And do you know why this happened? Because throughout this, the readings for this patient were throughout taken on NCT. And NCT, if the patient squeezes, you're likely to get a very, very wrong reading no matter what anti-glaucoma medications you give. And when we gradually took off medications, our intraocular pressure was completely normal without any medications. So do remember that the NCT is a screening tool only and not a guide to clinical decisions. Don't use it to diagnose or take decisions for glaucoma. The 4 pillars of glaucoma diagnosis. Now, this is a homemaker who came to us with intraocular pressures of 19 and 21 millimeters of mercury, good vision, thin corneas. So you would typically, and as you can see, the disc is quite okay. So at this situation, you would want to make a diagnosis of ocular hypertension. But unfortunately, that was, and this was treated as an ocular hypertension, disc suspect for quite some time. And over a period of 2 years, the visual field was very, very in between and did not show any disc defects typical of glaucoma. And the 10-2 was performed. because the disc I thought was suspicious, which turned out to be normal. So we can leave this calling as ocular hypertension or disc suspect at this point, or perform an OCT here, because what you see here on the red-free photograph is nerve fiber layer defects inferiorly in both eyes, and the rim also looks a little suspicious. So this suspect actually became a glaucoma when we performed OCT and saw changes on the RNFL deviation map and the GCA, which correlated with what we saw clinically. So when we performed a DVT, the pressures came up to be quite high for this thickness, and this was a proper glaucoma. So do not forget to examine the nerve fiber layer, low magnification, wide beam, green light, and sorry, I'm going in the other direction. So examine the NFL to complete the ONH exam. Repeated measures will be able to give you a true peak. And do not forget that too, the trio of disc examination, visual fields, and OCT, the disc photos are really, really helpful in many circumstances. And one very small point about this unfortunate patient. This patient was diagnosed as ocular hypertension and treated with one single AGM elsewhere. And this is her OCT from the examination 2 or 3 years back. And the patient was quite happy with the medications, but she suddenly presented to our emergency with sudden sudden diminution of vision, circumcorneal congestion, pressures in high 50s, and had to have a PI because she had a closed angle. And this is what the left eye looked, the right eye looked after resolution of the acute angle closure attack. Just because the physician here who could afford an OCT did not afford to do a gonio for this patient. So the moment you think of glaucoma, the first thing that you have to think of is gonioscopy. If you can afford an ASOCT like Casia, probably that will help and maybe close to replacing or substituting gonioscopy. But till then, please do perform gonioscopy for all patients the moment you think of glaucoma. Another thing that happens very often is a patient who presents with normal disc and fields, but very high IOPs. And at this point of time, many of us get confused. The commonest cause that we have in our population, especially in the age group of elderly patients, is pseudoexfoliation, which will reveal itself. Usually when you dilate, then you can see if the pupil is spared in this kind of a patient. So perform a dilated slit lamp examination for these patients. And other common causes when you have very high IOPs with normal disc, and maybe not normal, but subtle findings are Posner-Schlossman syndrome, juvenile open angle glaucoma. Do not again forget angle closure and steroid-induced glaucomas. Many of them might be using or traditional medications or steroids through other non-medical sources. So I just have the list of take-homes from the 4 cases as a summary here. You can spend a few seconds looking at it. But I would like you to remind you as ophthalmologists and glaucoma specialists, our job is to pull this Trishanku out from this zone of glaucoma suspect. And whether you do call it glaucoma or normal, but do that as soon as possible. And your skills as someone who is diagnosing glaucoma will depend on the number of patients that hang around in a clinic being labeled as glaucoma suspects. The fewer of them they are, the better it is. Thank you so much.
Thank you.
I'd
Thank you,
just like
Dr.
to clarify a little bit that, we tend to use ocular hypertension, disc suspect, glaucoma suspect, almost interchangeably, but actually there is a vast difference between them. So an ocular hypertension is a person in whom the IOP is on the higher side, but on the disc, there is absolutely no evidence of glaucomatous damage. So you cannot show a disc like you showed us at a cup disc ratio of 0.7 and say ocular hypertension. It has to be, sort of 0.3, 0.4, maybe up to 0.5. No RNFL loss, nothing else to be able to say this is ocular hypertension. The moment you start getting disc changes, then it became, and raised IOP, it becomes a glaucoma suspect. And if there's just the disc changes without any raised IOP, I would sort of think maybe you could term it a disc suspect. What do you say, Harsh?
Yeah, I think you're quite right, ma'am. But I think again the cupping is like he also said, one has to really wonder if there is any neuroretinal rim defect. And because we may have even 0.8 cup, but the rim is absolutely perfect, there is no wedge defect. So I wonder if I think we have gone into too much into cup disc ratios. So one would I'd rather totally avoid that and just look for is if there is actually a damage. So
Wonderful. Wonderful,
so,
absolutely. RNFL defect with a raised IOP becomes a glaucoma suspect.
that
Without an
changes to
RNFL
glaucoma.
defect. Yeah. Okay.
And
Good.
one more point I want to check with you, ma'am, because CCT, he said importance of CCT, but CCT to me is a very tricky business because especially some of the thicker CCTs, I had a fallout when there was 624 millimeter, this thing micron, and pressures of 24. I said, let it be, and I'll call him later in 6 months. The fellow didn't turn up for 1 year, 2 years, and when he came back, he had a damage. So I would like you to comment whether how much one should really depend on the CCT, because so many people have been taught this. Still in every seminar you see them reducing the, okay, this is CT, one normal is 530, so I'll reduce so much pressure. What is your comment on that?
I think over all these years, the thicker CCTs I actually don't take into consideration very much because all the RCTs from the US were done on those CCTs. So you have some sort of idea that, okay, yes, I mean, the pressure is high, keep it on follow-up, follow them up. What worries me is the thin CCTs. And I have recently been doing a lot of follow-up on patients who progressed despite target IOP. And almost 50% of them were because they had CCT. And even though the target IOP was achieved with the correction and everything else, they seem to continue to progress. So I would look at the thin CCTs from the point of view of maybe lamina cribrosa being predisposed. But a thicker CCT, I think, just needs follow-up. I think the thicker CCT, we shouldn't sort of dismiss, but they should be followed up reasonably in sort of 6 months or so.
Vanita, please.
I mean to say, ma'am, a thinner CCT is more dangerous than a thicker CCT in terms of glaucoma, in the sense like in terms of requiring a patient follow-up and chances of progression in these patients.
Absolutely. Yeah. And I would say that, thin CCTs from the point of view of the Caucasians is 550. For us, anything that comes to 500 or less than 500, I am very, very careful that the pressures are kept really low for those patients.
Any other comments?
Yes, first of all, congratulations to Dr. Siddharth for such a nice presentation. Just one addition to what ma'am has highlighted and everything beyond that. Disc ma'am is very beautifully described. Just one addition that if there are, because since this program is basically oriented for the comprehensive ophthalmologist, so not a single reading of IOP should be considered to start a glaucoma treatment when the disc is normal. As it was highlighted very beautifully that we have to take the history in detail. Could be a steroid-induced glaucoma or any secondary glaucoma, what ma'am pointed out in the very beginning. So always whenever we are going, even if we see that the disc is healthy and everything is fine and the pressures are going up to 25, 26. So instead of directly putting, and that too the readings are with 80. So instead of putting the patient on treatment, that's better that if we go for a DVT, or if not possible, then go for a repeated twice or thrice examination with the AT. Thank you.
Thank you, Dr. Shweta. Dr. Mayuri ma'am, want to add something?
Just 1 second.
Sorry, sir.
No. Siddharth, I think one of those pressures was around 27 on 80, was it?
That was the typo. made a mistake in copy pasting. It was 24 and not.
Okay, fair enough. Because if everything is normal, what we feel is that if it goes up to 27, 28 at any point of time, then I think we should treat.
Right.
So
That
we
was
need
missing.
to treat, you said, na?
Yeah.
Yes.
Okay, Vanita, please go ahead.
Mayuri ma'am want to say something? No? Okay. So now we move on to second important aspect of glaucoma suspect patient is importance of history taking and a comprehensive eye examination. What you should look into the eyes when you start suspecting a glaucoma by Dr. Devang Amon. Devang, please.
Yes, I'm just sharing my screen.
Thank you.
Is the screen visible?
Yes, it is visible. Yes.
At the outset, I would like to thank AIOS and for giving me this opportunity, since this is mainly targeted for the general ophthalmologist. So I would keep it simple. The importance of history and comprehensive eye examination. So at the outset, coming to history, the first and foremost thing that we look is basically the patient comes with blurred vision. And as has been discussed, that patients who come with the acute rise in IOP, they're usually patients of acute angle closure glaucoma. They can be post-cataract surgeries, glaucomatous crisis, juvenile open angle glaucomas, or pigmentary glaucomas. And there may be a myopic shift, especially in cases of malignant glaucoma, uveal effusion syndrome, or hyperopic shift. Along with blurred vision, patients can have colored halos, which are basically because of acute rise in IOP leading to corneal epithelial edema in patients with increased IOPs, and patients with have ocular pain, characteristically acute rise in IOP in acute angle closure glaucomas with unilateral headache and blurring of vision. In patients who are in younger patients of congenital glaucoma, they can present with blepharospasm, lacrimation, and view of thalamus. What is important in the past history is what one has to elicit whether their activities, like whether they are sleeping in prone, whether they are doing particular yoga poses, weightlifting, or a sports person or a runner, or wear tight neckties. There can be history of blackouts, which usually happen if the IOP is more than 50 millimeters of mercury, which leads to impaired vascular perfusion of optic nerve head, and they are associated with carotid disease. More importantly, history of trauma, in which post-traumatic angular recession glaucoma can be there, and very history of massive blood loss, which are basically seen in cases of normal tension glaucomas. And family history is very important, especially in cases of juvenile open angle or angle closure glaucomas or congenital glaucomas. And it is important to screen the first degree relatives, or if there is a significant family history. In demography, older age is an independent risk factor for progression of ocular hypertension and glaucoma. And angle closure, usually we have seen more in cases of females, whereas pigmentary glaucoma is more in cases of males. In systemic history, hypertension, diabetes, and thyroid diseases are associated with open angle glaucomas, and elevated BP basically is associated with elevated IOP, increasing the risk of glaucoma. However, excessive BP lowering in glaucoma patients may cause a drop in ocular perfusion pressure and subsequent ischemic injury. So this is also important. And diabetes mellitus, there is a greater likelihood of progression of glaucoma in patients with diabetes. In systemic history, one has to ask for if the patients have asthma or cardiac disease, because these are contraindication for giving anti-glaucoma medications like beta blockers. Any presence of renal disease, contraindication for carbonic anhydrase inhibitors. If there's a massive blood loss or hypotension, they're usually associated with normal tension glaucoma patients, cortisone secreting tumors, and any systemic syndromes that can be there. In history of medications, anticholinergic cholinergic drugs, especially antihistaminics, antispasmodics, antidepressants, or Parkinsonism drugs, they may precipitate angle closure glaucoma. One has to ask for that. Use of corticosteroids, which is an important cause for secondary steroid-induced glaucoma in our country, especially being used for VKC or inhalers for asthma or any dermatological creams. Systemic beta blockers can also lower IOP, which can lead to a false impression of normal tension glaucoma. So this has to be asked before making a diagnosis of normal tension glaucoma. And use of any anticoagulant, especially before doing a laser or iridotomy or any surgery if required for the patient. Socioeconomic history is important to ask for affordability or the cost of medications, and any ocular history like myopia or any uveitis or any previous ocular surgery is important. On systemic examination, if there are, apart from the ocular presence, if there is flattening of the upper part of the lips, or there are microdontia, hypodontia, or presence of a facial hemangiomas, all these can be associated in patients of Axenfeld or Stooge-Weber syndrome. In comprehensive examination, along with visual acuity, extraocular examination, pupil specially to rule out RAPD, slit lamp examination, IOP, and gonioscopy, and a detailed fundus evaluation is important. So if you look at the ocular examination, starting from the eyelids, we can see whether there's a presence of any hemangiomas or if there is, trichomegaly. Cornea, they can be enlarged corneal diameters, Harb's striae, corneal edema, pigments over the endothelium. Also, one can see the ocular surface of the patient. Anterior chamber, one has to, on the slit lamp, one can do a anterior chamber depth using the von Herrick, presence of any cells or flares, and hyperoleon. So for the general ophthalmologist, basically von Herrick is wherein the slit of the slit is made at the nasal end of the nasal or the temporal end of the cornea, and the thickness of the corneal thickness vis-a-vis the anterior chamber depth is marked. If it is less than or equal to 1/4, we consider it as shallow, and these patients should undergo gonioscopy. On looking onto other like the lens, we can see pigments over the lens, or specifically target sign, which can be seen, pseudo exfoliation material over the lens. There can be a mature intumescent cataract, there can be microspherophakia, subluxation of the lens. Pupillary reaction, especially RAPD, should be ruled out. In iris, there can be posterior synechiae, there can be iris bombay formation, sectoral iris atrophy, pupillary rough atrophy. There can be polychoria, iris atrophy, and neovascularization of the iris, or there's a history of trauma, there can be sphincter tears. Looking at the sclera and episclera, one should look for dilated tortuous veins, which can happen, which are basically, and limbal hemangiomas. In the vitreous retrolental cells or vitrectomized or oil-filled can be looked for. Fundus, apart from looking at the disc, what one has to look out for is to look out for changes of diabetes, vascular occlusion, vasculitis, any choroidal hemangiomas, or choroidal effusion, which are basically causes for all secondary glaucomas that was discussed in the beginning. On gonioscopy, what is very important in comprehensive ocular examination is whether to look for the angles, whether it's open or it is closed. If it is closed, you have to do a manipulation gonioscopy and look whether there is a synechiae and extent of the synechiae. So these are this is slight video in which you can see on the right side that it is an entirely open angle, whereas on the left side you can see the angles are narrower vis-a-vis the one on the right side, and on manipulation it is not opening much. And as the patient is seated on the slit lamp, one can also visualize the optic nerve head on the same sitting and look at the details of the optic nerve head to complete the glaucoma evaluation. So this is the case which was referred, and it's a 47-year-old male who had history of pain, redness, and watering since 2 months, and he was referred as a case of anterior uveitis and was started on steroids and had a pressures of 36 and 38. However, on an anterior segment examination, what we looked for was the cells flare was not basically there were very minimal cells flare to call it a anterior uveitis. In fact, the entire endothelium had pigments over over the endothelium, and on doing the gonioscopy, it was highly pigmented. It was 4+ pigmentation, and on disc evaluation, the left eye had slightly more cupping vis-a-vis the right eye. And on gonioscopy, the patient was systemically he had only hypertension, and on gonioscopy, characteristic concave iris configuration was not visible to us. However, we could only come to the diagnosis after doing a UBM, that it was a pigment dispersion syndrome and not anterior uveitis, which was referred to us. So all this was possible because of a good clinical examination, which had helped us in making the final diagnosis. Thank you for the patient listening.
Thank you, Dr. Devang, because none of the glaucoma can be diagnosed with complete ocular examination and history. I think the rest other is just support us in diagnosing the disease. Comments from chairperson and panelist, please.
I think this was a very good presentation by Dr. Devang, which highlighted to us that, any abnormality in the eye needs to be picked up and can or may be in the future associated with glaucoma. So one has to, as I was saying in the introduction, be aware that, we don't only see open angle glaucoma in this country. 1/3 of the patients we are likely to see are secondary glaucomas, 1/3 are angle closures. So we should be aware that any abnormality, and it's quite amazing that it's the anterior segment abnormalities that alert us to the fact that, yes, look carefully, there may be either current or possible glaucoma in the future.
Thank you, ma'am. Any other comments?
History of yoga and drinking a lot of water together should also be asked for. And small subtle sign like a small sphincter tear somewhere can be a guideline towards the traumatic glaucoma, or black ball sign in the gonioscopy. That is also helpful.
May I say something, Dr. Vinita?
Sure, sir, please.
There are 3 points which I would like to raise. First is that we are passing through a phase of almost an epidemic of steroid-induced glaucoma. So any young patient coming with glaucoma, especially where there is a slight amount of cataract also, is steroid-induced glaucoma unless proved otherwise. It can be as innocuous as something like oxytocin being given to the cows and buffaloes. Thus, the amount of steroid intake in our society is increasing by all possible means, including this one, which I said. And Posner-Schlossman syndrome is another thing which everybody has pointed out, but I would still like to point out because it comes as waxing and waning pressures. The other thing is, when you are taking the history of refractive surgery, it should not be taken in front of the spouse, because many of us undergo this and do not inform at the time of wedding. वो पहले ही करके वो सोचते हैं चश्मा उतार दो नहीं तो शादी नहीं होएगी. So third point which I want to raise is there is always a bias in the diagnosis. In individual practitioners, they are generally afraid, so they tend to overdiagnose. And people in institutions, especially in the government institutions, tend to discard the diagnosis of glaucoma. So all of us need to understand that we might be biased and we need to overcome our biases and go only by the objective history and examination. Thank you.
Thank you, sir. In my
Yes, Rupa.
practice, I have seen that people, they don't tell you that they are using anti-glaucoma drops. So many of the patients might be using anti-glaucoma drops also. So sometimes
Yes.
they are being falsely labeled as anti-G because they don't tell us that they are being using glaucoma drops also. Dr. Shweta, please.
Yes, ma'am. So just taking the continuation of NTG forward, whenever we are labeling anybody NTG, always the diagnosis of burnt out glaucoma should be ruled out with a careful history and a careful examination. History may be asking that any kind of previous trauma surgery has been done in the eye, or any past treatment has been done. So that is very important because NTG should always be made as a diagnosis of exclusion. Thank you.
So, but I thought this seminar is all about glaucoma suspect, right? So it is just whether it is there or not there types. So I think that is what we are trying to discuss. And one very important thing is that when we are taking the history, because many a times we are, if everything is pretty much okay, especially in cases of ocular hypertension and the pressures are little plus minus, maybe 24, 25, rest, all the things are normal. It is very important for us to ask for the family history, like Agmo has so beautifully actually detailed everything. So one
Thank you, sir.
important thing is, so we have to be very careful that what is the family history. So now, luckily, because of the WhatsApp, you tell them, okay, bhai, just get the field records or the whatever records are available. And so many times you'll just see the cases that have been presented that fields are normal, disc is normal, one NCT pressure of 23 or 22, and they have started medication. And now the whole family is, oh, glaucoma ho gaya, glaucoma ho gaya. So I think whenever the family history is being taken, we have to be very clear what was the extent of the damage that we have to really find out. Thank you.
Very true, sir. The families with large disc and large cup, I think probably because one is being misdiagnosed, then every member is putting the drops. Thank you, sir. Thank you so much. Yes, Dr. Vanita.
Ma'am,
Unmute,
please.
please. Unmute.
Yeah, I'm coughing so much that I'd rather keep myself muted. Anyway, the point I wanted to make was that we keep stressing on the fact that we should not be doing pressures on NCT, yet it's a very widespread practice. And maybe, just maybe, pressures are being rechecked on Goldman only when the pressure is higher, 21. But under those circumstances, what we are doing is we are presupposing that glaucoma does not happen at lower pressures. So if NCT is low, are you not supposed to be checking GAT anyway when you are, you have a glaucoma suspect, NTG suspect, whatever. So that's a point I wanted to make, that we cannot presume that glaucoma does not happen at lower pressures. So we will do GAT IOP only when pressure is high, not when the pressure is within normal limits.
So, Vanita, the problem is that we are talking for general practitioners. Okay. Now, what is happening is, and I talked to one of the MRs, he says everybody, a lot of rich practitioners have gotten 80, nobody does an 80. Okay. So, you are very correct. Ideally, everything should be done. But what is happening is that only NCT is being done because many of them actually don't even know how to do an 80.
Well,
So
I have
what should we tell them? Well, because they are let us take a part of a small practitioner. He is very scared sending the patient somewhere else. That is what is happening so many times.
So
Dr. Harsh, even if he knows, there is always, time is money for a private person.
no,
So they
it's
don't want
okay
to
to
spend
do
time so many times.
it's okay to do NCT as a screening, but the moment, when we are talking about a glaucoma suspect and especially NTG, there has to be some changes in the disc. So we have to actually be skilled enough to pick up those changes. That's my point. That
I
not
think that is
case.
the crux. Very good. because I
It
think
is not about pressure. Pressure comes only when you are going to make an etiological diagnosis and when you're going to treat the patient. Pressure does not actually come into the equation of making a diagnosis of glaucoma at all.
so. I think each practitioner can actually dilate and have a good look at the disc. And we've been teaching
Yes.
for so long how exactly. So I think this is the critical point, Vanita, that pressure is not that important. And,
Yes.
and so many NTGs, and we all know. And even otherwise, the studies have shown that 30-40% may be having a normal pressure when they come to you and they are otherwise glaucoma. So, and they may not be having a field with them, these practitioners. So the one thing they can do is really dilate, have a good look at the disc with a red free. All of them have a slit lamp. So please do that.
Dilate when they can rule out angle closure.
Sure.
No, if they're dilating and they're not sure, let them make the patient sit over there for a long time so that if attack is to happen, it is happening in front of them.
Okay.
True, sir. It is very important that underdiagnosis and overdiagnosis of glaucoma, we just want to check on it because there are so many cases which are roaming around. They are really requiring medicines and they're not putting, and there are certain patients, those who are putting medicines, not only the medicines, but they are carrying the psyche of glaucoma along with them. So we have to be careful and making them refer to a glaucoma expert is one good advice, but then upgrading ourselves, looking into the optic disc more carefully. And that is the main aim of this webinar. So we move on to another topic by Dr. Sushmita, but because Dr. Sushmita is traveling, she will be joining later. So can we have Dr. Ankur Sinha? Dr. Sinha, are you ready? Will you be
Yes,
able
sir.
to take
Yeah,
it?
yeah. I'm
So
ready.
I told you that the disc first and then the fields, but unfortunately, you have to take the fields first. So you have to identify how the glaucomatous fields look like and then how to differentiate it from a non-glaucomatous fields. Thank you so much, Dr. Ankur.
Yeah, is my screen visible?
Yes, sir, you can.
Thank you.
Slideshow. You have to make it slideshow, sir.
Okay.
Yeah, perfect.
Thank you, AIOS, and thank you, Dr. Vanita. So we had a webinar on this glaucoma suspect, but I would take you through the visual fields and the visual fields where we do not have glaucoma, and if we have glaucoma, how they confuse us. The idea is to communicate with the field printout and to come out with what is the best for the patient. So we all know the glaucoma is a group of disease having a characteristic progressive optic neuropathy. So the field should also progress to have glaucoma. That is one thing I want to be very, very clear, because sometimes we just see a field defect and we start treating the patient. So a role of any investigation is to understand and define the normal, to understand and define the disease, to compare normals with the abnormals, and these abnormals may not be actually the diseased ones, but they may be the abnormal visual fields or abnormalities in the performance of the visual fields, and to tailor the dose of the treatment for that particular disease, especially in case of progression of glaucoma. So glaucomatous defects in early forms could be because of the partial notch or loss of axons. They may present as paracentral scotomas. As the disease advances, we can have more widespread damage. So we can have nasal steps in the next phase. Then we can have further advancing of the notch, reaching the disc margin, where we would have arcuate scotomas. These are typical arcuate scotomas we can have. And then they can come in combinations, like it could be a biarcuate scotoma in an advanced glaucoma, or an arcuate scotoma with a nasal step, or it could be a generalized depression with a arcuate scotoma or a generalized depression with a nasal step. So these are the few things we would have to look for in almost all patients in which we are suspecting glaucoma or we established glaucoma in these patients. So first question is this glaucomatous? So a comprehensive ophthalmologist as a casual look may say yes, but why not it's a glaucoma? The answer here is these are deeper defects far in the periphery and they are more peripheral. And this is not typical of glaucoma. So you look at it, these are zeros here in the raw data. This is far more peripheral and you would find the glaucomatous defects somewhere here, usually in case of established glaucomas. And this is the typical glaucomatous type of defects, a picture which is showing you the type of glaucomatous defects you can have in patients of glaucoma, and not these in the far more periphery. So this is the same patient after lid taping. This was the disc of the patient, which typically, in this case, we can see that the disc is not corroborating this with the kind of visual field defect we have, and it is the defect because of the lid drooping. So after lid taping, the defect has gone away. Now, again, is this glaucomatous? You have patients, we do repeat the visual fields. There are two visual fields. We see there is a change, but it looks like there's an inferior arcuate and there's a superior notch. And this variability is because of the learning curve. But yes, this would fall into an arcuate scotoma because the disc findings support that this is glaucomatous visual field defect. So this is typically in the germs area, and we do have an arcuate defect here. Now, again, a similar kind of arcuate defect we have. We have the nerve fiber layer thinning superiorly, but if you look at it, the isn't rule is being followed. So we have to compare the disc for the other side. We can see that the thinning of this eye is better appreciated as we compare from the other eye, and then we can see this thinning is cause of this defect in this patient. Now, these defects again are not typical of glaucoma. They are too peripheral, and again, they are very sharp. You have a lot of zeros in the far periphery, and these are typically because of rim artifact, and this is because of the improper rim placement and not because of any glaucomatous defect we can suspect of. Sometimes we get this kind of defects in a patient. We are doing visual fields. These are because of high false positives and fixation losses. And the patient is a trigger happy patient who keeps on pressing the triggers. You explain the patient that yes, you do have high pressures. You have been sent for glaucoma evaluation. We expect a normal visual field for you. And this is not a test for your kind of acumen. It is what we want to test in reality. So whenever you see the light, you press the button, and this is the same patient once you explain them how to perform the visual field. So this is another patient who is diagnosed as glaucoma, has been in YAG-PI, well controlled. Discs are definitely glaucomatous, and the patient was supposed to be progressing on these visual fields, and he was advised a filter surgery. Now, this is another common mistakes that sometimes can happen. We have to be very, very careful here. So we just repeat the visual field. We find out that yes, the patient is progressing, but the mean deviation has gone down as compared to what it was in the previous visual field. And even the pattern standard deviation has gone down. And here the right eye visual field has been done on the left eye program. That's the problem here, because the software identifies the blind spot as the pathological scotoma, and the software's blind spot is seen by the patient. And the increase in mean deviation progressively was because of the early cataract in this patient. Now, this is another patient, a 45-year-old female with vague complaints of ocular discomfort. She has a strong family history of glaucoma. Mother and maternal grandmother had lost vision because of glaucoma, hypermetropic, open angles with narrow entry, discs are healthy, cupless, and they are having a good NRR. And these are the visual fields because the patient is very, very apprehensive. And then somebody has kind of suspected glaucoma in this patient. So we see the patient has repeated visual fields which are unreliable. We also get a visual field done, and we're not very happy with this generalized depression when we see at our center. So what we look into, when we look into the detail, the reason was the perimetrist has put minus 3.5 in place of plus 3.5. The moment we put correct power into the patient's lens holder, we get absolutely good visual field in this patient. So sometimes we come across these kind of visual fields whenever we do. These are not glaucomatous, they are cloverleaf, because the patient has responded in the initial part, which are white here, and in the peripheral part, when the patient has lost interest, fatigue, or inattentive, they are all black. So this is a diabetic lady, hypertensive, old lady with borderline IOPs, referred to as glaucoma. But the history here was sudden difficulty in vision. So before dilating, we did a gonioscopy. It was in open angles. We just got a visual field done because that's the practice we do. And then we saw the disc. The disc is absolutely healthy. So there's something else which is to be done. And dilated eye examination, which is an important part we had already discussed. So you dilate and see this is an inferior BRVO, which is causing this kind of visual field defect. And this is not a typical glaucoma we are looking at. Now, this is another patient who is referred to as glaucoma with these kinds of visual field defects. You have an OCT which is showing you nerve fiber layer thinning of both eyes, right eye lesser as compared to the left eye. But even in this OCT, you can make out the one which has been referred with the same printout. This disc is much larger as compared to this disc. So there's something abnormal in this disc, which can give a suspicion of something else which is going on. The other eye does show these kinds of defects. So what we do again is we dilate the eye exam, and this is the fundus photo. We can see there's a nerve fiber layer defect, and a closer look at the disc shows you there's a disc coloboma, and this is not going to progress. So as I already said in the beginning, that the disc, the visual fields and the disc damage has to progress to be labeled as glaucoma. So this is going to be stable for most of the life because this is a disc coloboma. Now, glaucomatous defects should correlate with the disc, like as in this case, we have an inferior nerve fiber layer defect, and we have a superior early arcade scotoma, which is coming up in this patient. We follow up this patient, it looks like it is progressing, and then we can see that there is 1 0 in the central 10 degrees. This warrants a 10-2, which is very important part now. So whenever you have any 0 in the central 10 degrees of the 1030-2 or 24-2, always go for a 10-2 in these patients. So in the end, I would just say that there is a peculiar arrangement of nerve fiber layer. This nerve fiber layer leads to a typical pattern, and this nerve fiber layer loss gives you a pattern of visual field defect, which helps us in better understanding of disease. And it is very important to know that we are treating patients, not the visual fields. Thank you.
Thank you, doctor, for the showing us the wonderful correlation of non-glaucomatous fields. And if you have a suspicion, it is good to repeat. Thank you. Thank you so much. Comments from ma'am?
I was just saying, Ankur, what a nice presentation. But I think what we need to remember is that when we're talking about suspects, as Harsh said, we have to keep coming back to the fact that we're talking about glaucoma suspects. So in those patients, what you're most likely to see is maybe a row of peripheral points lost or scattered parietal points lost. So in these patients, it becomes very difficult to say, is there actually a problem or is it just a learning curve? So as Ankur pointed out, you have to do a number of fields to actually figure out whether there is something actually there or not. And the other thing is that we keep talking about glaucoma as being mild when the MD is less than 6 decibels. But what we find is that in those eyes with less than 6 decibels of loss, you'll find that these are actually the only things that you're likely to see, maybe 1 or 2 points in the nasal area, 1 or 2 peripheral points. So we do walk a little bit of a tightrope till we are actually convinced that the problem that we are seeing or the spots that we are seeing are actually reproducible. So reproducibility is probably the most important thing to say, is this an glaucoma suspect or not?
Thank you, ma'am.
Thank you, ma'am. Yeah, that's what is important, because the field has to be reproducible, and I mean they have to correlate with the disc findings which we have with us.
Thank you, Uncle. That was really wonderfully done. And
Thank you.
Like he rightly said, but I'll reiterate that point because he showed the BRBO. There are so many beautiful arcuate defects with BRBO. There's so many. But what also happens is so many patients I have seen, there is a peripheral cryospot, and somehow or the other it turns up as a nasal step. It's a consistent defect, and the patient is being treated for years and years. Myopic degeneration, so many things. So please, the retina thing, and rightly you said that this thing must correlate. Unless disc and field correlate, you have to check what is wrong.
In this continuity, I would say that neurological fields are also one of the trickiest fields, but most of the time the patients are not glaucoma and they have been diagnosed as a glaucoma, but basically they have some or the another neurological problems, the well-known being a pituitary adenomas. So we have to be careful that whether these fields which we are looking for is a glaucomatous or not. Any other comments?
So basically, we have to just, ma'am, I'm just taking that discussion forward. What you said, that we have to differentiate between the neurological defects. So always the pallor should be differentiated from the cupping. That's the most important thing, because pallor, if you look casually, definitely it needs to be looked with attention along with the health of the NRR. So that's the one take on that. Thank you.
Thank you so much. So now we will come to the disc, which Dr. Sushmita is going to highlight more, that what is the disc dilemma and what are the mimickers and what exactly the glaucomatous disc look like. Dr. Sushmita, please. And thank you so much after traveling from Bhatinda back to the...
No, I'm in Bhatinda.
Thank
I'm
you
just
so
back to the meeting. So this was even further north. I was getting back to the hotel. It wasn't the Wi-Fi. Thank you so much for accommodating, and thank you for having me on. Hello, everybody. I'm sorry I didn't join in time. So Dr. Vinita has asked me to talk on this dilemma, and I was listening on the phone in the car. I think most of my talk has been done, so it's made my life easier. So of course, this is the normal disc. We know that. Salient things to look for. So obviously, when we are looking at a mimicker, it's important to just refresh what a glaucomatous disc looks like typically. And this is what we've been taught: 2 aspects of the disc, 2 aspects of the neuroretinal rim, 3 aspects of the cup, position of the central retinal vascular trunk, and peripapillary features of optic disc hemorrhage, RNFL assessment, arteriolar diameter, and choroidal atrophy. So in the absence of all of this, if you have something which is not correlating to this potpourri, really we should start thinking of not glaucoma. And I'll just go across to some of the cups and some of the cases that were interesting. So of course, the large discs have been spoken about. This was a very, very large disc, as Dr. Siddharth was showing. And the fields are normal. Of course, we need to get into a conversation with the patient that I am going to follow you up for maybe a couple of years. But the salient features are it's concentric, and there's no pallor, and it's pretty much uniform, and the neuroretinal rim is quite healthy. And now that we have the tools at our disposal, we can actually show the patient that here is your OCT and it looks all normal. So I'll just share a couple of interesting cases. Pressures 25 and 36 millimeters of mercury, small crowded discs, and an obvious larger asymmetric cup in the left eye with an inferior RNFL defect. If you watch it very carefully on dilatation, because a casual observation would just think that this disc is normal. And sure enough, she did have visual field early defects. But unfortunately, a lot of glaucoma is being diagnosed and treated on the colors of the OCT, in addition to the NCT. In the other eye, you know why, despite there being a thinning compared to the 172 versus 92. That's a huge difference in RNFL. But this RNFL number or value falls within the normative database of the OCT machine. And therefore, this will be termed green. Now, the problem is if they're going to walk around with an OCT like this and Goldman applanation and IOP has not been taken, probably this glaucoma would be completely missed. So it comes up at normal, but it's not really normal, and we know that. So it's been flagged green, but just to highlight that. The other great mimicker is in high myopes. It's very, very difficult to diagnose a disc. And if I give this to most of us, we would be in problem. And the OCT is not very useful. We know that. There's no segmentation at all. There is too much of peripapillary atrophy. We had this wonderful tool called the HRT, which we don't have it anymore, but I could dig out some of her pictures, and actually it's the disc on the right which is nearly all right, and the disc on the left is also has a reasonable rim. Now, this would be a great mimicker of glaucoma, and the only trick that we usually do is to get the fields and hope, I don't know why it's moving, all right, to get the fields and just follow it up and hope that it doesn't change too much. But that's one place where the visual fields would be so very important. So the last case which Dr. Harsh was talking about, large cups with visual field defects. So this is a large cup. She's come with a visual field. But of course, the thing that is not matching is that it's a 1-quadrant visual field defect. And the other thing that doesn't match is that we're only looking at the disc when it's undilated. And of course, our OCT tells us that it actually looks normal. And here you are, that's the scatter laser of the BRVO once you dilate the patient. So if we don't dilate and we don't look at it closely enough, I think we'll miss it. And it's likely, I've seen a lot of cupping with PRPs and other lasers as well, because I'm sure ganglion cells are being damaged with the laser, and I'm sure the axons are drying up. So I'm quite sure that the OCT is also going to have some red, but then it doesn't make it glaucoma. So this is another small disc where, again, I'm showing the OCT images because it is a fact that most people come at least for a second opinion simply because of OCT findings. So this one had a loss of vision since a month, left RAPD and red on the OCT, and therefore equal to glaucoma, and referred to the glaucoma clinic. But this patient has a very pale disc, and she was hypertensive, and this is likely old AION because there was nothing else to suggest glaucoma in this eye. So now we know that we need to be very careful when the discs are small. We've all talked about the large discs, but when the discs are small, and if you're going to rely on imaging, as most people are relying more and more on imaging, remember, glaucomatous small discs can be absolutely green on imaging, and non-glaucomatous small discs can show up as absolutely red on glaucoma, so red on OCT. So we need to be very careful when we're looking at small discs as well as when we're looking at large. So this was also interesting. This woman was one-eyed. She had lost one eye completely to trauma, and she was told that the left eye now has glaucoma, and she was quite distraught. But she was carrying this OCT, which showed up this little red here, which is why she was told she has glaucoma, and she was put on treatment. But if you actually looked at it, there's no segmentation here. So this was very interesting. This is actually just a Weiss's ring. And this Weiss's ring was preventing the light from going in. And this is the red thing that was coming up on the OCT. But she was also thought to be glaucoma. So a mimicker could be just an OCT diagnosis and nothing else. So if there's something abnormal there, the importance of clinical examination can't be overemphasized. Of course, all cupping cannot be glaucoma. And as Dr. Vinita said, it's the temporal pallor, which is so important. So 12 pressures, again, as diagnosed as NTG, but there's progressive ganglion cell loss and the damage of LHON. But remember, toxic and nutritional deficiency could appear just the same. These discs look rather unremarkable. This young man was a smoker and an alcoholic, and he had these discs which were a little weird, but he didn't have very good vision. And his OCT again turned out to be green and nothing else. But then if you just look further, the GCA is completely red, which means the papillomacular bundle is gone. And when we actually just saw his vitamin B12 levels, it was severely depressed. And actually, injections of Neurobion helped restore a little bit of the vision. It came with about 660, and they improved by about 2 lines. So sometimes this temporal pallor and GCA completely gone can mimic a glaucoma because there's something weird in the disc which looks a little pale, but again, it didn't match too much, and he couldn't do his fields because his vision was so bad when he came to us. Again, cupping, young man, referred as NTG. Now, a young man with NTG is a little abnormal. And again, the discs didn't look very pale, but there was something going on, and the RNFL seemed all right. But when we looked at the GCA, to our horror, it was actually a lovely homonymous loss. And this is, remember, this is at the macula, and these are the fibers which go in on the center of the disc. So this homonymous thing, and when we did the field, we would never have imagined that it came out to be the parietal lobe tumor, which we would have completely missed. But actually, this was cupped. So it's cupped, but it's not glaucomatous. It's something else. So there might be very, very ominous things going on if we are not sure with our functional and our structural testing. And we might have completely missed this had we not done a GCA analysis on them. So in summary, I would say approach to any patient always depends upon what it is. And as we go along in time, what it is evident more often than not. by just sound clinical judgment. Thank you. And all clapping is, of course, not glaucoma.
Thank you, Dr. Sushmita. It is always wonderful to listen to you. It's a good learning for all of us because very suspiciously looking disc comes out to be normal sometime. Comments from chairpersons and panelists, please.
Yeah, I think again, let's step back to the glaucoma suspect and remember that, isn't rule still holds in a very, very large number of patients. It may not hold in everybody. It does seem as if, a thinning of the inferior rim is something that we should look out for and note to say that, yes, this is a thinning of the inferior rim, and therefore this patient should be followed up looking at that. We also need to keep remembering and telling ourselves that, things change over time. So when the patient is being followed up, it is important to not only keep doing OCTs, but also keep looking at the disc and the retina because things are likely to change there as well. So I would just say, go back a little bit to the basics. Isn't rule is something that we should still be keeping an eye on. And it's a story I tell a lot of people. An aunt of mine came and I looked at the eye and, one fine, the neuroretinal rim was good, and the other one showed mild thinning. And I told myself, I'm sitting in the glaucoma clinic, I'm seeing too many glaucomas. Anyway, I told her, come for a follow. Being relative, she did come for a regular follow. Came back 3 or 4 years later with a defect. So I think, noting these things when you make an examination, important. I remember GC and Ravi Thomas's those diagrams. You just have to make a round circle, put a pointer and say thin neuroretinal rim. If you can say pallor with thin neuroretinal rim, you've gone one step further. So these small things an OCT may not be available to everybody. OCT may not be read by everybody. So at least these clinical things that we can do should definitely be part of our examination.
True, ma'am. None of the machines can replace a good clinical examination.
One small point is that a lot of kids are brought to us, I think to everybody, one of us, 12, 13, 14-year-old child or even younger, and they have suspicious looking cup disc ratios. And invariably they'll squeeze their eyes and the pressures will come to, God knows what. And the whole family is crying, coming over there. I think the first thing is to be done is to make the parents sit and check their discs. And suddenly you'll realize that actually it is the parents who should be investigated rather than the kid. And one thing to the
also if the parents have a large disc, it may just be a physiologically large disc. Yeah.
And one we have been telling this again and again, but my humble submission to the general practitioners, please, on seeing one column of red in the OCT, don't. Every day I'm getting a patient who's running, crying, sir, उन्होंने बोला 90% damage हो गया. The field is bloody normal. What the hell is happening? So for God's sake, at least if you are suspicious you are doing anything, please at least don't tell the patient like that. It just shatters their lives.
True, sir. Young patients, especially, they become panic because they read everything on Google and they think that they have become blind or something. So we have to be careful saying the patient that you have glaucoma. Any other comments? Now we'll move on to compilation of, I think, the whole thing, that how do we proceed in a suspect case, by Dr. Pradeep Vyas, sir.
Yeah, good evening, everyone. Thanks, Dr. Vinita and AIOS for this opportunity. Can you see my presentation?
Sir, yes, but request, please make it slideshow.
Is it
Yes,
all right?
perfect. Perfect, sir. Perfect.
Okay. So, there will be lots of repetition, but still it's a very important topic. And, the entire webinar is on that, how to proceed with the glaucoma suspect cases. So whenever you have a patient of glaucoma, we do a detailed workup. History taking is very important. Dr. Devang Angmo is already highlighted. Intraocular pressure, including DVT, has to be done almost in all cases. CCT, yes, does have a value, and as has been pointed out by many of you, that thinner corneal thickness is more important than thicker corneas. Gonioscopy is very important, mandatory, and in fact, all these things has to be done in all patients having glaucoma. Optic nerve examination and the RNFL evaluation, probably, in my opinion, has the highest sensitivity and specificity in diagnosing the glaucoma. And if you suspect the patient having a glaucoma, then visual field examination and RNFL thickness is done. Now, let us talk about the glaucoma suspect. When you suspect a patient having a glaucoma, the first point is the intraocular pressure. Whenever the intraocular pressure is high, the patient is suspected to have a glaucoma or ocular hypertension. But remember one thing, that high IOP is not always a glaucoma. Most of the time, it's a erroneously recorded high IOP. The patient does not have a glaucoma, and the most notorious for that is the NCT. The NCT give very erroneous high reading in most of the patient. So it is always better to do a good IOP evaluation or examination or measurement through Goldman applanation tonometer and make sure that the Myers are very appropriate. There should not be very thick or thin Myers. Then you have an angle closer suspect when the patient has a shallow SC on the Van Herrick's. The DIS suspect, the most of the patients labeled into the DIS suspect category when they have a large cup, which has already been discussed. The cup asymmetry. On the one side, say for example, the patient has a 0.3, on the other side, patient has a 0.5 or 0.6 cup, then it falls into a DIS suspect category. The disc hemorrhage, if the hemorrhage appears at the margin of the disc, then if the patient has not done the visual field properly, and RNFL thickness has been discussed by Dr. Sushmita, and Dr. Harsh was also telling, if you have a red disease, that does not mean that the patient has a glaucoma. What is the prevalence of a glaucoma suspect in India? If we talk of the patient population of more than 40 years of age, then almost 4% patients have a glaucoma, and around 10% of the patients are glaucoma suspect. In the general population, in entire population, around 1% patient has a glaucoma, and around 4% patients are glaucoma suspect. It is almost 4 times than the glaucoma, the patients are glaucoma suspect. The POAG and PACG suspects are almost equal. As in clinical practice, we see that they are almost equal, so the suspects are almost equal. However, mostly in secondary glaucoma, the suspect word we do not use, but still, if the disc is normal and the patient has uveitic glaucoma or maybe neovascular glaucoma and the disc changes are not there, then patient can be labeled as a secondary glaucoma suspect. The conversion rate of glaucoma suspect to glaucoma, at least in ocular hypertensive, is 1:20 to 1:10 on 5 years follow-up. But the ocular hypertension study number 2 and 3 has suggested that almost 50% of the patients turn into glaucoma over 20 years of follow-up. So when you see these kinds of discs, you see that this disc shows this disc is a very large disc and a large cup, has already been discussed. So most of the general ophthalmologists, they would diagnose this as a glaucoma, but Ideally, this patient is not having a glaucoma. However, if you see this disc is a small disc, and if you do not see it properly, you would miss this disc as a non-glaucomatous. But you can see that there is an inferior notch and RNFL defect over here. You can see over this looks pretty normal disc, but you can see that there is a RNFL defect over here. There is a hemorrhage, which clearly indicate that the patient has a glaucoma. You can see that there is a hemorrhage over here. There is a RNFL defect over here, but the perimetry is absolutely normal, because all of us knows that most of the ganglion cells are dead, then only the defect appears on the perimetry. Approximately 25 to 40% ganglion cells should die, then only on the functional test you see the defect. So this is a classical glaucoma when you have a RNFL defect correlating visual field changes on the functional test. So this is a ideal case of glaucoma. You see this deviation map. Most of the patient now comes to you with the OCT printout with the diagnosis of glaucoma. The disc is slightly large as compared to the normal population. And on the deviation map, you can see that, there is here or there some yellow or red defect, but these are not true glaucoma. That is a problem with the OCT. So don't consider these patients as a glaucoma, and you have to explain to the patient that, uh, the OCT alone cannot be confirmatory for glaucoma diagnosis. This has already been discussed by Sushmita as well as by Dr. Ankur. Uh, you have not dilated the fundus, you have not dilated the pupil and seen the fundus, seen the disc and done the perimetry, and you can see that superior arcuate scotoma. And if you dilate, you will see that there is an inferior BRVO. For all glaucoma suspect, whether you suspect the patients on Von Herrichs as a shallow SE or not, but you have to put the gonioscope if the pressure is high and you suspect the patient having a glaucoma. On the OCT, you can see that, the patient has a narrow angle, and all these patients need a YAG laser peripheral iridotomy. So the gonioscopy is must in all patients, irrespective of the status of anterior chamber by Von Herrichs. You have to put the gonioscope and see that what is the status of the angle. It is not necessary that all the patients would be having a narrow angle glaucoma, but you may find the angle recession, the pigment dispersion, the pseudo exfoliation deposit, and so on and so forth. So the gonioscopy is very important in all the patients having a high intraocular pressure, irrespective of the other status. I will take you through two cases of mine. You can see that this patient, he has a tilted disc, and there is an inferior conus on both the sides. And if you see very carefully, then you feel that the inferior rim is very, very narrow. So this patient was suspected to have a glaucoma, and then we did the perimetry, and there was a correlating changes on the functional test. There was a superior arcuate scotoma. And when we did the OCT, yes, it was again correlating, and there was a inferotemporal RNFL defect in this patient. You can see over here. But remember one thing that, if there is a congenital anomaly, then there might be a RNFL defect as well, and it would remain so for entire life. And you can see that I have completed almost 15 years follow-up of this patient, and nothing has progressed. It's always the same. This is another patient of a glaucoma suspect. Came to me with a high pressure, 56-year-old gentleman. The right eye disc was very healthy. The left eye disc was a little suspicious. And when I did the perimetry, it was absolutely normal, except a few spots over here and here. But the patient was not willing to take the treatment because, he went to some other doctor as well and said that your perimetry is normal. So obviously, yes, you do not have the glaucoma. OCT was done in the right eye, it was absolutely normal. In the left eye, there was a little bit of thinning over here. But still, no treatment was taken by the patient. And a few years later, again came and there was a definite inferior notch with the RNFL defect. And you can see that this has significantly reduced the thinning of the thickness of the retina. And on the functional test, there was a superior arcuate scotoma has appeared. Remember one thing that if the patient does not understand the disease, and if you are not able to explain to the patient that what disease he is likely to have or he is having, and what kind of a defect this disease may cause, and that would remain permanent, then probably the patient would not understand the severity or the gravity of disease and will not take the treatment, and that is what would happen a few years later. So it is the responsibility of not only uh, we as a glaucoma expert, but even the general ophthalmologist also should respect the diagnosis made by their colleague, and they should not ask the patient and show their extra knowledge that they don't have a glaucoma. So if you have a patient of glaucoma suspect, then the holistic approach is that do the Goldman appellation torometry to measure the intraocular pressure with a good mass. If possible, do the DVT, measure the central corneal thickness. Gonioscopy is mandatory. Always take a disc photo to assess the progression in the future, and the functional test still remains the gold standard. The OCT, yes, nowadays all of us have started performing in all our patients. And yes, in some patients, we pick up the defect in the early stage. And the correlation between the various tests is very important. If the disc does not correlate with the OCT or the perimetry, then the patients may not have the glaucoma. So what are the risk factors where the glaucoma suspect would convert into the glaucoma is the age. Older is the patient, higher the risk of the glaucoma suspect converting into the glaucoma. Family history of glaucoma, the high intraocular pressure at the time of presentation, the high vertical CD ratio, the thinner cornea, disc hemorrhage, pseudoexfoliation, myopia, and steroid use or abuse has already been discussed by almost all the speakers. So you divide all your glaucoma suspect into three categories. Number one, the low risk, who has either no risk factor or less than two risk factor. So they need less frequent follow-up. But yes, still all these patients require a follow-up, and less likely they would require the treatment at the time of presentation. In future, yes, obviously they may require a treatment. And as I said earlier, ocular hypertension 2 and 3 studies suggest that almost 50% of ocular hypertension patients convert into glaucoma. If the patient has a moderate risk, that means that patient has a more than two risk factor, they needs more frequent follow-up, and more likely they would require a treatment. And high risk patients with many risk factors need frequent follow-up, and almost all patients would require the treatment. So glaucoma suspect is almost 4 times more common than the glaucoma. Many of the glaucoma suspect has potential to become glaucoma. Single observation cannot confirm the diagnosis of glaucoma. Holistic approach is required to diagnose the glaucoma. All suspect does not require treatment initially. However, they do require a close follow-up. Identify the high-risk cases amongst the suspect, and these require more close follow-up. Thank you very much for your patience hearing.
Wonderful presentation, sir. Thank you so much for so well covering the whole aspect of a glaucoma suspect. Comments from chairperson and panelist, please.
RIP. Rest in peace. I think everything has been said.
Very well said, sir. So truly a compilation of everything.
I would like to use the words of Dr. JC. He says the glaucoma suspect is not a disease. It's not a diagnosis. It's a diagnosis of limitation of our knowledge and the limitation of technology available to us. So we need to reduce their number. We need to minimize these numbers by improving our skills and by improving the technology that we have at present with us. So a few things which I would like to add to this. First is that classically we are taught that asymmetry and progression, these are the hallmarks of glaucoma diagnosis. So in case of any doubt, please follow up the patients carefully to demonstrate progressions, presence or absence of progression. That will help you. And asymmetry has to be matching asymmetry. Asymmetry in glaucoma will be there not only in OCT, not only in the fields, but also in the intraocular pressure. So there has to be, even if it is within the normal limits or it is beyond the normal limits, in case there is an asymmetry, the higher eye with higher pressure should have more changes only then they are significant. So asymmetry has to be matching. And secondly, it is possible. I think Dr. Sushmita pointed it out, but I would like to, because it's very, very important, I would like to say again that there can be evidence of glaucoma on the visual fields, OCT, as well as RNFL. Still, the patient may not have glaucoma. Like certain cases, there can be loss of ganglion cells, but there is no pressure rise and there's no damage and it's not going to progress. Like I have seen myself a case of large patch of choroiditis, healed choroiditis, which had all these changes but had no glaucoma, did not progress over years. So these are the few words I wanted to say.
Thank you, sir. Any other comments, ma'am?
I would just like to say that, we keep quoting the OATH study, the ocular hypertension treatment study. And, very clearly, Pradeep has pointed out 3 times that almost 50% of them showed some progression over 2 decades. The point that is made by the OATH study is that you can afford to wait to start treatment. Because their patients, their ocular hypertensives are probably all 50s and 60s, they are not likely to sort of last for too long. But our suspects, if I'm not sure if everybody else agrees with me or not, are now coming earlier and earlier. 40s is something that we are seeing all the time. Harsh was talking about children who come because somebody is diagnosing them as suspects. So I think we have to be careful in actually recording whatever we see. And I keep telling my patients that the first field or the first OCT that is reliable is the one that you're going to hold on to for the rest of your life, because thereafter, everything is going to be compared to that baseline investigation. Even if you, again, I'm saying for the general ophthalmologist, even if it's only a diagram that has been made, that is the baseline against which he's going to be compared for the next sort of for the rest of his life. So yes, I think it's important for us to be careful with diagnosing suspicion, follow them up, because what do we lose nothing by following them up for a few years. And if they remain stable, that's fine. If they actually progress, we know that we've caught them early and we can treat them. The last slide that Pradeep showed, I thought was the most important, about risk factors. There are so many known risk factors now. We are not in the old age where we used to sort of, I remember as a junior resident saying thyroid disease is a very common sort of risk factor for POAG. And now we find that it isn't. It's all these other things: age, baseline IOP, baseline cup disc ratio, all the other sort of things we hope we never get, like sleep apnea, patients who are using steroids. So if we do look for these risk factors and we say, 1 risk factor, 2 risk factors or more, then I think we're actually going to catch our patients who are more likely to progress and keep them on closer follow-up, and let the others with low risks sort of come more intermittently.
Thank you. Very truly said, madam. There was one problem, like most of the patients, we feel it as a glaucoma suspect are not a real glaucoma, but they are already on medication. So that becomes really difficult that you have to stop the medication. So being a glaucoma expert, sometimes you have to stop the medication and keep the patients on follow-up. Like many of the doctors, they write glaucoma suspect and then they start the treatment. So I always tell, if there is a suspicion, you should not write the treatment, you should follow. If you write the treatment, means you have diagnosed the disease and start treating the disease.
So, Dr. Vinita, I'm tempted to go back about 20 years when I used to hang on to every presentation made by Madam and Dr. Harsh and Dr. Pradeep and everybody trying to figure out what to do. And one of the first glaucoma talks I heard was Dr. Harsh saying, if you do glaucoma seriously, you'll spend far more time taking people off meds than putting them on. And it's really stood the test of time. That's it. If you really do it seriously, you'll have a lot of them who you need to stop medications.
Yes, true. And many of the secondary glaucomas, they've been well diagnosed, like it's a uniocular disease, but then the patient are unnecessarily putting the drops in both the eyes with the fear that they will develop the disease in the other eye. So sometime uniocular glaucomas, we have to stop treating the other eye also.
The other common scenario is if an LI has been done for a PSC or even a very early PSCG, and for years they're on that Combigan, which is post laser, until with normal discs and normal fields. So that's another scenario where I've stopped
Yes.
medications many times.
Yes, true. But then few of the doctors, like they go to the primary doctor where they get the treatment for years like this. So they said आप डाल रहे हो इसीलिए तो आपकी बीमारी रुकी हुई है वरना तो आप blind हो जाते. So sometimes you have to spend lot of chair time even stopping the drug also.
But let
More,
me tell
I
you,
would
some of
say.
my loyalists patients are those who have stopped drugs. They will just come in every year to say hello and thank you, but they are very happy with me.
They are the most, they are the best patients.
Yes, they're so
Those who
happy.
understand the disease process and then that fear has gone that yes, definitely they have a glaucoma. Basically, I feel that having a glaucoma is not that dangerous rather than having that fear of becoming a blind is more dangerous.
That's true.
But
So
I
that
think
is one.
I think Vinita hit the nail on the head because we sell ourselves so badly. We keep telling everybody everything is a risk, everything is possible blindness. I think it's time for us to sort of also say that things have changed.
Yes.
I mean, even if you're a suspect today, it on its own it's going to take some time. If it does happen, we have the treatment available. So taking care of the mental state of the patients, I think, is something that we do very badly. We really, everything we do, whether it's an iridotomy or medications, we're talking about risks of this and risks of the other and risks of the other, without telling them that in the long run, the chances of progression is there. It's a very slow progression. We have many things that we can add to stop things from progressing and definitely from you getting blind.
But what I feel is that there has to be a disclaimer as well. When we are actually telling them that today you don't have glaucoma, you should say today you don't have glaucoma. We don't know what the future holds because age is the biggest risk factor.
True.
That is very important because I've had patients coming back to me and saying, "Sir, आपने तो कहा था नहीं है glaucoma, फिर तो मैं गया ही नहीं कहीं." तो अब ये कौन समझाए उसको? So very rightly said कि भाई अभी नहीं है, बाद में क्या होगा मुझे नहीं पता.
That's
So,
how I
Dr.
put it.
Harsh,
Currently no evidence of glaucoma.
I always tell my patients whom I take them off the medication or whatever way I feel that this kind of patient that we are discussing today, that you don't have glaucoma, but still, as far as your age is concerned, this itself is a risk factor. You must have a regular eye checkup every year. So this is what I tell every patient, that not only glaucoma, there can be development of other diseases as well.
True.
Another very
So the
important,
bottom line says that the close observation with frequent follow-ups is the most important thing what we can do with the suspects.
so
Well, you
what do
may
you
not
do
need
for a
frequent
patient?
for everybody.
Yes.
Dr.
Yeah,
Pradeep highlighted so well,
Yes.
you
he's
can
given all
risk
the
Risk factors.
stratify. Yeah, you can risk stratify
Risk factors.
and based on that. Yeah.
Yes.
What do you do to
But
a patient who comes to you कि सर मेरी तो 10 साल से दवाई चला रखी थी उन्होंने, now you अब आप कह रहे हो ग्लोकोमा नहीं है? Because that is a very tricky situation. He is very angry with the original doctor. So
Dr. Harsh, I must confess here that I have myself taken the patients off medication after many years on whom I had started medication myself. So
That is
there are
okay.
certain situations, there are certain, you
That is
grow
why
with
you
time,
are
you
here.
learn more with time. So this is always possible. This is always possible.
So exactly, very nicely said. So you have to explain to the patient कि अब नई नई मशीनें आ गई हैं. So now we are more informative that डॉक्टर ने उस टाइम जो किया था वो ठीक किया था. So please be careful not to, once you are stopping the
them out.
medicine, you have to tell them that नहीं उसने शुरू वाले डॉक्टर ने गलत नहीं किया. Otherwise there will be a big mess.
Yeah, true. I agree. Thank you. Thank you so much. And now we move on to our next talk by Dr. Vanita Pathak Ray, spotting red flags, identifying high risk patients. Though we have started discussing with Dr. Pradeep sir, now she will be giving us certain case scenarios where we can see how efficiently we can manage our glaucoma suspect for future. Thank you, ma'am.
Thank you so much, Vanita, and thanks to AIOS and Dr. Santosh as well for this invitation. What I would like to do actually is digress a little bit. I want to point out certain aspects of management. Not necessarily patients who are, just suspects, but they're walking in to me for the first time. So spotting the red flags. First, we need to understand what we mean by red flags. So this is either a clinical feature or symptom that indicates a patient may have a serious underlying condition. It can help raise a clinician's suspicion, act as a warning or danger sign. And when red flags are present, either further investigations are indicated or a referral is spurred or should be spurred. So let me take you through three case scenarios in rather great details, and then we can obviously have a discussion at the end. So here we have a 48-year-old female who complains of bilateral pain with red eyes. First, it started with the right eye, then it went to the left eye. That first red flag, lots of red flags in this. Then nausea and vomiting. Second red flag. And patient gave history of retinal laser, so obviously was very much in the system, seeing somebody only 4 years ago, and was a high myope, -10. An asthmatic, but nothing else, was on inhalers. And previous, I think I stopped counting, 4, 5, 6, I don't know how many, but net effect was everything was done on NCT, which was unrecordable, and advised Combigan and pilocarpine. Patient had stopped it for 2 days because did not feel any relief. Of course, NCT, a third red flag, and of course, being asthmatic and on Combigan beta blocker, should not really be given. So she had count fingers vision, much poorer in the left eye, very difficult examination, not only because she was uncomfortable, but because she had nystagmus and exotropia. But you could see she had very severe ciliary congestion, she had shallow AC. So obviously that's your fourth flag. And I managed somehow to do a Goldman applanation, and it was the maximum 72. If you've done it, 72. Beyond 72, you can't go. So I needed to relieve her pain. So mannitol was the best, and 500 milligrams of Diamox. Pressure came down. She was happy, and that's when I could take her photographs. You can see the right eye much worse than the left eye, and pilo effect still hanging on. So her pupils look small, which is good for her, but you can see they're very shallow AC. Remember, she's a myope, -10. So this kind of a scenario should obviously always raise a red flag. Next day she was comfortable, but obviously pressure was still high because she was only on 2 topicals and oral steroids and Diamox. Gonio was closed. Looked like 360-degree pass, mannitol was repeated, and then because it was bilateral, you needed to rule out anything systemic, usually a drug, and so I did a B scan and there was no effusion. So then you have to think about what is happening locally. So you have to do a UBM. It was formed, I saw a very formed and expanded, as you can see here, posterior chamber with very convex irides. So you know there is some element of relative pupillary block in both eyes, and therefore PI was done in both eyes. So this is how she presented to me after, of course, mannitol, and this is after PI. How her eyes completely cleared away. And of course, she was almost falling at my feet because she endured 15 days of intense pain. After PI, vision was 636 and count fingers in the left eye, pressure still not controlled, and of course, AC still shallow, and gonio looked like 360-degree pass once again. And lens was extremely thick, not too much nuclear sclerosis, but very, very thick. And dragging of the disc and macula on dilatation. So she was born premature. She was one of the very few laser receiving, very earliest laser receiving ROP babies. And 4 years ago, she had barrage laser, 2 lattices. That is how I unraveled. So this is how she looked post LPI. And you can see the ACD still very shallow, LT very high. For a lady who's still not 50, that was pretty thick lenses, and her axial length 24, so within normal range. And this is how her fundus looked. So the key points here I would like to say is that early recognition of a shallow AC and high IOP would have definitely rid the patient of pain much earlier. Whenever there is bilateral angle closure, usually it has an underlying cause. A systemic drug is the commonest. You have to rule it out. And myopes can also have angle closure. I now have a huge series of myopes having angle closure. And what I can tell you now, an updated version, she has maintained her vision on pressures of 15 and 14. She is not on any medication. This is now 3.5 years, very nice, stable AC, deep ACs. Staying on the subject of AC depth, I hope you can see on the left-hand side, which is the right eye of the patient, the AC is shallower. So that should actually, unilateral now shallow AC should raise a red flag. This is now an even younger patient, 45 years, female. She was referred, seen only by one ophthalmologist, as far as I can remember now, pressure of 30. No family history of glaucoma, no comorbidities. Her vision was 618 with -4.5 diopter, sphere in the right eye, and left eye was absolutely normal. Slit lamp examination did show that she had a shallow AC, and she had a very significant cataract in the right eye, unilateral cataract, very, very difficult to explain, but maybe her myopia was index in nature. So her pressure when I measured it was 60, 13 in the other eye. On gonio, all 4 quads were closed, indentation extremely difficult, as you know, at high pressure. Sine wave sign was present, the other eye was normal, and a very cup disc on the right side, normal on the left side. So let me just remind you of how she presented. Right side, very shallow AC, left side, normal. So what I had to do, of course, because of high pressure, presentation of high pressure in a unilateral shallow AC, had to do a UBM, and on UBM you can see not only is the AC shallow, but you can see a very high lens vault, causing leading to angle closure. You can also see bulky anteriorly rotated processes, ciliary processes, and obliterated iridociliary sulcus on that side, not so much on the other side. So like I said, lens thickness was high, and lens vault was also extremely high. And post LPI, the gonio was again could not be opened, and possibly had more than 3 quads of peripheral anterior synecdoche, and dilated discs were also the same. You can see now her CCT was extremely low, and maybe that is the reason why she had rapid deterioration at the pressures she had. Axial length and ACD on biometry also gives you evidence that the right side was different from the left side. The HVF, unfortunately, she presented with very advanced loss. That's the left eye, completely normal. This is the right eye, unfortunately, very, very advanced loss with very small island of vision on 10-2. So the key points here, I would say again, that recognition of shallow AC should have happened on the slit lamp itself. And high IOP would have prevented that visual field loss wherever she went first. We have to remember that lens and all its characteristics, thickness, vault, relative lens position, are all causes of angle closure. Patient now, after her surgery, phaco ECP, maintains 6/6 central vision with controlled IOP and is drug-free. This is how she looks. Sorry, this was pre-surgery, and this is her latest 2024 visual fields. You can see it is maintained just because the pressure was maintained. And then I move on to the last case. Here seen by a general ophthalmologist, 57-year-old male who presented there to the general ophthalmologist with blur in the left eye for 3 months. He found pressures to be high, started a medication, and diagnosed it as POAG, as you can see in, although gonio was not documented, you can see what was sent to, what was with the patient. He also had a visual field test done, and this then produced the first red flag for me. You've heard Ankur speak very well. Changes that happen in glaucoma don't actually start on the temporal side. They start on the nasal side. And other than that, you also had the OCT. Now, you also heard about OCT, very asymmetrical changes. You can see that there are nerve fiber layer changes as well as GCC changes on the left side, despite the fact that the left disc is actually larger than the right disc. So there is a change, a difference, which is not accounted for just yet. So what I did, by the way, the patient had no comorbidity. This is what I found on my examination, that color vision was decreased in the left eye. That's the red flag. Vision 6669 is what we said. Then RAPD present. Devang told you very well. So examination should be complete. On the left side, sorry, I forgot to write that. And patient, because patient was already on medication, pressure was 16. What happens on gonio? Actually, the patient has occludable angles. So if the patient has occludable angles and presented with IOP slightly high, we know that this is primary angle closure. We still have to prove whether or not the disc is glaucomatous or not. So yes, that is my gonioscopy. At that time, we were still documenting on files. Now it's all on EMR. Then I can't show you all these lovely things. But I've also said, written over there, that the disc on the right side is normal, no NFLD, left side larger, pale disc, and NFLD. So my point was that the disc was non-glaucomatous. Diagnosed POAG elsewhere, unfortunately, this was neither glaucoma nor open angle. So I did a PI and a CCT after that, general workup for, thin CCT, but that's beside the point. You can see that the angles opened up, at least 3 quadrants. You could see posterior trabecular meshwork in both eyes. What's more important is that I could take fundus pictures now, and you can see very clearly that there is pallor of the rim on the left side. Larger disc, pale rims. Of course, that brings up a red flag. So you have unilateral pale disc. This is 90% specific for compression of optic nerve. So an indicator for an MRI. I repeated the visual field. You can now see that other than enlarged blind spot, so to speak, nothing else is visible. Just as a reminder, you can see the previous ones there. And MRI was done, and that did not reveal anything sinister, thankfully for the patient. But there were many, many, many red flags in this case, mostly related to clinical examination, where I would say initially it was incomplete, no color vision or RAPD documentation. Even though this particular patient did not have serious disease, but based on just these 2 findings, we can separate discs from being glaucomatous and non-glaucomatous. and or neuro-ophthalmological fields. Gonioscopy is definitely mandatory in all glaucomas, glaucoma suspects, you name it. And it should be correlated clinically as well. Then rim pallor went unrecognized. The disc was drawn, but there was no comment about the pallor of the rims. And a temporal VF change, highly unlikely to be glaucoma, and you must repeat under those circumstances. And OCT changes may be present in non-glaucomatous discs as well. So I started by telling you about red flags in glaucoma. It is a clinical feature or symptom that indicates that there might be disease. What happens is that we have to actually recognize it in the first instance. Our index of suspicion has to be high. We cannot, shift responsibility onto others. So when red flags are present, further investigations may be required. But we also need to learn the correct interpretation of these if we are ordering them. And when red flags are present, referral to a specialist may be indicated. Most are reluctant, we know that. If it is mild glaucoma, if it is only a suspect, it's all right, you're worried, you may lose your patient, but you really do not want to, lose an eye because of selfish reasons of losing a patient. In these 3 cases itself, you saw 2 patients walked in, 1 patient was referred. Thank you very much for a patient listening.
Thank you, Dr. Vanita, for taking us some beautiful cases which were mismanaged and misdiagnosed. Probably it's a learning that how from the history to the complete examination, you can save the eye. Thank you. Thank you so much. Comments from panelists, please.
So as ma'am, ma'am has very beautifully highlighted the importance of proper examination and very correctly pointed out from the very beginning of the webinar today. A complete comprehensive examination, which because gonioscopy, as I say, it's one of the mandatory tools in the glaucoma clinic. Before we say any, sometimes the patient, they do come with us, like just sharing an experience. A patient used to come to me, like first time when he came to me, he was very apprehensive about the dilatation. And he said that whenever we dilate, anybody else dilates the pupil, he gets high pressures. The pressure, they shoot up like anything. And he was on uncontrolled, innumerous, I can say all drugs were there for him. And he had come for the surgery to me. And when I did a simple gonioscopy, it was simply beautifully plateau iris. The patient was put off all the medications and a simple pilocarpine helped the patient, and till date, the patient is being followed up with me, maintaining the pressures well within normal limits. So gonioscopy is that important for anybody to perform and diagnose anybody to have a glaucoma.
Thank you. Thank you so much.
Another important fact is that many a times we do a gonioscopy and then because of the paucity of time and all, we don't repeat it. But I think it is mandatory that every year when the patient, at least once in a year, even in open angle glaucoma patients, you should repeat gonioscopy. Because I've had instances where my retina chap said, "Bhai, jara karke ek bar dobara dekh." मैंने कहा, "भी open angle है, देखा हुआ है." कहते कर तो सही. And then I realized that, oh my God, it is actually now very, very narrow. So we have to be careful, and this is an examination which has to be repeated every time.
Yes, sir. As sir also said, no, that when the age increases, that itself is a risk factor because the lens thickness increases with age. So that calls for repeated gonioscopies.
Thank you. Thank you so much. With this, now we move on to another important, I think, futuristic topic, that how that AI is going to help us in glaucoma screening and to avoid such bias which are sometimes related to individual doctors. So Dr. Venkatesh is going to take you to AI in glaucoma screening.
Thank you, madam. I think I'll give a different flavor to this topic because somewhere in the discussion it came that we need to improve the skill or improve the technology. I think I'm going to just touch what we are doing something with this AI technology, at least to my knowledge, know what we are doing. So the main disclaimer is I'm not an expert, but someone who is deeply interested
in AI and its potential applications, wherever it is, and more so in ophthalmology and in eye care. And we all know AI is kind of automated system. You make a computer supercomputer, so it performs tasks which needs human intelligence. And also it can mimic cognitive functions, which is associated with human mind, like it can learn and also solve your problems. So it can screen for glaucoma also. So these are all the different terminologies. I don't want to get into it, but I'm sure we all know that AI, and beyond AI, you make the machine learn and also deep learn, which is a subset of machine learning in which there is an artificial neural network. Like our central nervous system, there is a neural network in those supercomputers which adapt and learn from vast amounts of data. And basically, if you ask biostatisticians, they may say it's a glorified statistics with all the supercomputers. But it is not as simple as that, because the machine is now learning and able to kind of tell even beyond what we are teaching it now. So basically, machine learning is supervised and unsupervised. Anything which is supervised, there is a human involvement. No, you are giving and you are annotating and you are kind of guiding the correct outputs. So whenever it is supervised, it is very reliable than the unsupervised one. You know, whenever you search of something, you get a lot of things which is related to that. So which is more like unsupervised learning. And it just takes raw data and converts it into a data classes. When you talk about artificial intelligence and eye care, I think these two things come in mind, right? Diabetic retinopathy and glaucoma. But diabetic retinopathy, I have just flagged it in green because we are in the next level for DR. That is because screening is a public health need. We know that any diabetic, you can put them on screening. But glaucoma, we are not very sure whether screening needs, even no, between glaucoma specialists, there is no consensus. Can we do a mass screening? If you say, we'll say it is very difficult. And then a single image is more than enough for a DR. Whereas glaucoma, we know, no, you need IOP, you need fundus image, you need other investigations. Diagnosis is very simple: NPDR, moderate NPDR or PDR, or classification of that. And training of this for the computers is also easy, whereas it is very complex in case of glaucoma. The labeling and training is difficult. You have to see the cup disc, peripapillary area, the vessel changes, and all that. And most of the algorithms, if you see in DR, are now tested in large and diverse data sets. Real world studies have happened. Whereas glaucoma is isolated algorithms, no, few here and there. And there are different studies which are coming up in the recent past. Cost effectiveness is already proven. Whereas here we are not ready even for those studies. And we have seen that all the big regulations approval has been there for DR. Whereas in glaucoma, we are still waiting. For DR and glaucoma, in India also, we have the CIDISCO approval, but not for glaucoma. But do we need AI for glaucoma screening? Definitely yes, because we know the burden and we know how many people are not aware and how many people are walking around us, and also the over-treatment and under-treatment and all those problems which we are seeing here. So there is no single screening test like what we see. There is a mismatch between the population and the ophthalmologists available. And also there is, no, we lack specialists who are trained to deal with glaucoma. So even if you diagnose a lot of these glaucoma, what are we really going to do? But at this point of time, what we see from at least research is AI can beautifully classify glaucoma and non-glaucoma. It can identify progresses. And also it can study some of the risk factors and also quality of life of these patients. So I'm not going to get into the convolutional neural network because I'm not a real expert. But basically, you can train the CNN model wherein it can look at glaucoma in different ways. So we wanted to understand the different studies which are done on AI, especially on fundus imaging, because we know there are work on OCT and HFA and all that. So we did a review work some time back to really see, and there were 33 or 36 very good papers between 2011 to 21. And of which we also looked at what approach they did. Now, many of them had a logical rule-based, and whereas some of them had the real machine learning, which is where you feed the data and you train the computer, and then it gives you a kind of an output, which is more accurate, and it can be even adaptable to complex scenarios. like some of the disc suspects or peripapillary changes or other defects in the retina, all that it can adapt to the complex scenarios. So, and then the problem is it needs large data sets and also maybe a kind of a black box model, where you can't predict a lot of things when you are putting into real world scenario. So what we found that one of the paper is again from in India, and also it's a local software, which is developed by a company called Remedio. I have no financial interest. And we had these Remedio cameras in all our vision centers. So we run primary eye care centers or vision centers to improve the health-seeking behavior. These are in semi-urban rural areas. And the telemedicine happens through teleophthalmologists, who are our senior residents. So there are technicians in the vision centers, and the EMR is entered with all the findings of comprehensive examination, and the teleophthalmologist does the examination through the telemedicine. So what we've seen is the Remedio, when we are using it, we also introduced the Meteos AI for DR and glaucoma. So it was not only looking at the cup disc ratio, it was also looking at the peripapillary changes and also the vessel changes. Now, even a small bend or change in the vessel, it can recognize. And it can immediately flag whether you need a referral for glaucoma. So why we wanted to try in vision centers is we were having a lot of false positive coming, especially disc suspects and all the suspects which we are talking about. And here it can also work offline. You don't need online. So it works even offline. And once you are in the cloud, you can always sync it with your data. And we were able to find some meaningful information, especially on glaucoma. It was the segmentation network gives the cup and disc outline, and the heat map around picks up all the peripapillary nerve fiber layer defects, the asymmetry in the cups and all that it picks up because the machine is now learned to do this. So because of want of time, I'm not going to get into the vision centers. This is just a minute video on vision center, but I'll just show you what happens to your patient. So there are two people. One is a coordinator and other is an optometrist, which you see on the video. Basically, the coordinator registers the patient and checks all the basic tests, like a blood pressure is done, a blood sugar is done. And also immediately we take a non-mid fundus image wherever possible, if the media is clear. And the Meteos AI is done. Within 10-15 seconds, it generates a report. Now it can look at DR, glaucoma, and ARMD within 10 seconds. And then you get an image report, which is uploaded into the electronic medical records, which can be seen by the telemedicine doctor at the end of the examination. So then an optometrist does all the basic tests. And once everything is over, a telemedicine doctor is there, like how you see on the screen, who gives the advice to the patient. Either they are referred or they are sent home with glasses or prescription. So what we wanted to do is we wanted to look at this software, how it helps in our vision centers. So what we did was we compared AI results and the teleophthalmologist diagnosis, and these patients were brought to the base hospital for a glaucoma specialist assessment. So around 300 patients were recruited from 6 satellite centers. So what happened was they had a comprehensive examination, like clinical history, visual acuity, slit lamp, IOP, and a fundus photo was taken with the Remedio non-mydriatic camera. And then AI and teleophthalmologist diagnosis. So the teleophthalmologist did not know the AI report. They reviewed the history and disc appearance, but they don't have the AI results. But the staff have both the results. Depending upon what refers, whether the AI refers or the teleophthalmologist refers, they refer to the base hospital for further screening. And then in the base hospital, the ophthalmologist or the glaucoma specialist looked at every information, did HFA, OCT, and then labeled them as suspect or glaucoma. So what we saw was, if you see the referable glaucoma, AI versus the teleophthalmologist, the sensitivity was around 73 and the specificity was 98%. But at the same time, when you look at AI versus the glaucoma specialist at the base hospital after the patients came here, the sensitivity was as high as 91% and the specificity was also 91%. So when you take the AI versus the teleophthalmologist and the glaucoma specialist, you see a gross difference. That is because when you compare the AI versus the teleophthalmologist, the AI had a very less false positives, because it was not only just looking at the cup, it was looking at all the other details. And whereas the teleophthalmologist, whenever they say a big cup or some asymmetry in the cup and disc and things like that, they would refer. And this false positive was much, much less with the AI when compared to the teleophthalmologist. So this really helped us. And the other part was the teleophthalmologists were also able to learn from those images now. So when the AI picks up glaucoma, it says no glaucoma. Now they are looking at details of the optic nerve, the cup, the peripapillary area, the nerve fiber layer defects. So it also helps us a teaching tool now for the teleophthalmologists who are the senior residents who do that. So something like this, you know how media picks it up, and now we are encouraging all our vision centers beyond Pondicherry now to employ this technology. So to make sure that we make a better screening. But definitely there are limitations. You need very good data set to train. Now the remedial people have done it to some extent, but we are still working hard to improve and make sure it's also validated in a better way. So we all know when there is a garbage in, even a powerful computer model will have garbage out. So at present, we know that if you can give all this information, you can definitely detect glaucoma. Now, much better than some of the clinical problems which we have and the technology problems which we have. AI can bridge a little bit to improve the technology to detect and also identify progresses. But I'm not going to get into detail of this, but in the future, we can do a lot of things with AI. But the problem is, we don't know whether it is going to de-skill physicians or replace some of the tasks. It can't. But it can enhance the physicians and it can definitely provide better care, especially for glaucoma suspects, which we are talking about. Because the overdiagnosis is a big problem, like many of you have highlighted this. Thank you.
Wonderful, sir. I think it's an icing on a cake where AI is coming up with the doctors to improve the diagnosis and so also the progression. Because Manadeep sir only told that if we review our cases in cool environment, take the printouts and see, sometimes we do little mistakes in our busy OPD. So probably that time the AI is going to shorten our mistakes. I think that's what I learned. And I got this Remedio camera to just see how efficiently this is diagnosing in my diagnosed cases. So I found it it's very good and it's diagnosing well, especially in glaucoma cases. Like when there is a suspect, definitely it keeps that there's no glaucoma. They try to analyze glaucoma only. So that's a good part of it.
No, we have to keep in mind it's only looking at optic nerve head now. No, it is not looking at all your risk factors to really say. No, it says refer or not refer at this point of time. But once you start feeding the data with all this, and then if you have all those data with the optic nerve images, it'll still give a better picture to us. It'll say definitely there is a risk. No, these risk factors you need to follow up after 6 months or 1 year or whatever we are talking today may happen with the AI with the future. But if your electronic medical record is so powerful with all the information which that needs, and if that data set is also trained like that, that is what is very important. Even a BR Vivo, we can train that this visual field is because of BR Vivo, or this is because of an AION. No, this image is like that. If you are training it properly, then the output will be really interesting.
True. I have a point to make, if I may. I have a question. Is there a risk or a danger? Now, you are doing it in your network, which is great because you have your own employees. There is some degree of control over, what there are standard operating procedures. There are rules and checks in place. What happens when individual practitioners acquire this and, like an OCT, then start diagnosing glaucoma? I ask this because I have actually come across a few patients have come to me with the report with not necessarily a printed report saying that this doctor has done this imaging and said that I have glaucoma. So is there a danger?
Definitely. See, again, we are looking at now only as a screening tool. You are only screening and suspecting or referring them for a kind of opinion to rule out or to start the care or whatever it is. So definitely it's a screening tool. That is why I said when you compare with DR, there is a long way to go with all our information because it is so complex because of the so many factors involved in glaucoma. Whereas DR, they were immediately able to get FDA approval, CE approval, even the CID, SCO. No? The Indian approvals are all there for EDI, even for our local AI, because that is very reliable now. With one disc, very good image, you can definitely say whether it's mild, moderate, severe NPDR or whatever. You can classify and say this needs care or this needs follow. But in glaucoma, I think there's a long way to go. But at this point of time, you can say it's a screening tool. It is not a tool to decide whether you are glaucoma.
Right. Divya, who's part of Remedio, she was a fellow. She was a fellow of mine, a very favorite fellow of mine. And, I brought up this point with her. I've done many, many discs with her. She sent me many, many images saying, ma'am, what do you think about this one? What do you think about this one? But, and then I found that patients are coming saying that some image was taken and I was told I have glaucoma. So, and drops were started. That's the problem. The drops were started. I mean, it's okay if it's been put in a mild way that yes, there is a suspicion of glaucoma. It has to be evaluated in greater details, and then we think about management, because the implication of management is lifetime. It's like a jail sentence.
No, at this point of time, the reports are generated like that. No, it says you are suspected to have glaucoma. You need further evaluation.
That's good. That's good. I don't think in the beginning it was happening like that.
Madam, any comment?
I would also like to say that I think as glaucoma specialists, we've been giving the wrong advice to the people actually doing the software and the AI. I think right in the beginning, Dr. Harsh very clearly pointed out that, it's not the disc that we actually want to talk about, the cup disc ratio we want to talk about. What we want to say is there an RNFL defect or not? So I think if we can move this a step further and say, can it pick up RNFL defects with any sort of specificity? Maybe it would help us in going that one step further. Also, I think we've now we are over our time, and I think it's time to summarize a little bit. I think the presentations were very good. And I think when we think about glaucoma suspects, the variety of things that we are likely to see is so huge that suspicion is probably our biggest weapon. That as long as you keep a very high sort of chance of suspicion for every patient who comes to you. I'm not saying only glaucoma, but as glaucoma specialists, we look at glaucoma, but looking for an abnormality. And when you find a abnormality, the chances are that it can lead to many other things, including glaucoma. Dr. Harsh, would you like to sort of summarize as well?
I think everything has been beautifully said. But my one last point, summation to everybody who are listening as general ophthalmologists, please do not be scared of referring. One of my best patients are those whom I referred to a proper place, and they said, yes, we are so grateful to you, and they even bring their families because that generates faith. So don't be afraid that you lose those patients. As a matter of fact, they'll have more faith in you that you referred them to a proper glaucoma specialist for the right advice. And please don't leave them in a limbo saying, oh, suspect, okay, we'll see this. So what Vanita also said, tell them you don't have glaucoma at this time, but we will, in any way, at this age, we have to follow you up every year. So at least it is not hanging on their head that yes, there is a disease like glaucoma suspect. I think that's what I want to say.
Thank you so much. With this, we have come to the end of this webinar, which is being a part of AIOS. And I would like to thank Dr. Samar Basak sir, Dr. Santosh Unavar sir, Dr. Manoj Mathur sir for giving us this opportunity to create an awareness amongst the general ophthalmologist. And even we have learned a lot from this webinar. So I would like to thank from core of my heart, Ramanjit Siota ma'am. She's there. I think I have come in between the dinner and the this webinar. And Dr. Harsh Kumar sir, Dr. Satyan sir, and our panelists, Dr. Madhu Bhadoria ma'am, Dr. Manavdeep Singh sir, Dr. Mayuri Kamar and Dr. Shweta Tripathi, and the wonderful team of speakers. Like everybody has done a justice to their topic. Dr. Siddharth, Dr. Devang, Dr. Sushmita, Dr. Ankur, Dr. Pradeep Vyas, Dr. Vanita, and Dr. Venkatesh. I would like to thank all the audience and AIOS office people with us from past 2 hours. Thank you so much and good night.
Good night. Good night. Thank you. Thank you, everybody.
Thank you, ma'am. Thank you.
Good night.
Good night, everyone.
Good night.
Really? No. Really?